we'll move on. Can we have the pre-recorded video, please, for Dr. Mary Ho? Yeah, so unfortunately, she cannot get a visa to join this meeting. So we've got a pre-recorded video on surgeries for dislocated IOL. Can we have the audio, please?
Audio.
Quite challenging for us when we are handling with a dislocated lens, because usually the situation is complex. A lot of the time, you may be referred from the colleagues with a complicated cataract surgery, while because of the prolonged operation and manipulation, the cornea may be cloudy. The sutures may be, there may be a lot of the sutures and causing the excessive seal in the cornea that would also impair the surgical view during the posterior segment surgery. And also another scenario would be if patient receive multiple operations such as LD fixation, removal of the silicone oil, and for the period of time this sonnular status is being weakened, the patient may have dropped the whole IOL complex. The second scenario would be the presence of vitreous hemorrhage. For example, in a post-SF-IOL scenario, while on passing through the sutures may cause bleeding in the ciliary body, and a vitreous hemorrhage would also impair the general view for assessing during the pre-op stages. And in the case of prolonged aphakia, the patient often present with meiosis, and it would be quite challenging for removal of the lens and also for resuturing or re-anchoring of the lens haptic. So in the beginning, we have to assess in what situations, in fact, we are handling with, whether it's a complete drop of the IOL complex, or if sonnular support is in fact fair or adequate at one side while the other side was being dropped. So in that juncture, we may have to only replace or resuture at one side of the haptic. The type of the IOL that we are handling with, and also the capsular bag status, whether it's a prolonged fibrosed capsular bag, and it is very difficult to be separated with the intraocular lens. So these are the common IOLs that we have to bear in mind before handling of the dislocated lens. In the old days, we do a lot of the ECCEs for the dense cataract. The patient tend to be inserted with a PMMA lens. For the PMMA lens without anchor site at the eyelets at the haptic, it would be very difficult for resuturing the PMMA lens back to the sclera. So it is recommended the whole PMMA lens to be removed and reinsertion of a new intraocular lens. If the dropped intraocular lens is a three-piece one with a central acrylic optic and also the PMMA haptic, for example, an AIOL40E or ZA9003, that would be a good scenario that we can use the same IOL for refixation. For one-piece IOL, generally, we will recommend for removal of the IOL either in a manner by cut and explant or by twist and a removal approach. So we have to use intraocular agent to help us for removal of the lens. And for example, we have to use PFC to flow up the lens to the anterior chamber before we can do further manipulation. So how can we avoid retention of the PFC, especially when you open up the wound, it causes a bit of the turbulence by injection, and it causes a lot of the small globules formation of the PFC. And also, usually for a vitrectomy, we aimed for complete vitrectomy, but in a situations while the corneal status, the clarity is impaired, it would be very difficult to assess for any cortical features left in the macular region. So very good use of the TPA to remove the cortical part of the vitreous would reduces the chance of ERM formation post-op. Say, for example, this is one of my patients with the IOL dislocation explant and also reimplantation of the flange IOL using the Yamane technique. However, during the operation, after injection of the PFC, and I did not remove the PFC before further manipulation of the Yamane technique flange IOL. And because I open up the wound wide for the period of time, the infusion cannula kept injecting of the fluid, and it makes a lot of the turbulence flow. And despite multiple effort in removal of the PFC globules, there is retained PFC post-op. So during the second operation, how can I make sure that all of the PFC small globules are being removed? I injected the vision blue, and so that the small globules of the PFC stay nothing. In fact, there are multiple globules for complete removal. So there are tips for flanged IOL. So we have to make sure the wound creations, whether or not being 98 degrees apart for the anchor site is a good option. I think a slightly tilted approach would be towards the left-hand side would be a good approach, because the trailing haptic would be the one which is difficult to be threaded. So do we need to thread out one side of the haptic first before handling the other side? And because when you lifted one side first, the IOL centration is tilted towards the side being threaded out, and it would make the rest of the handling very difficult. And also, during handling of the needle baffles, if you put the baffles towards your side or make it the physiological position for threading of the haptics, it would be easier for the haptics to be stuck inside the baffle. So what are the causes for IOL decentration in a flange techniques situation? So this is a study published in Retina recently. So first of all, we have to make sure that the anchor sites are 180 degrees apart, because if there is any tilting, that would cause a significant increase in the cylinder. For example, 10-degree tilting would cause at least 0.5 or 1 diopter increase in the cylinder. We have to make sure that both sides of the tunnels are of equal length. So usually we will mark the site of entry of the needles and also the site of exit of the needles to be 2 mm apart, so that if one side is longer and the other side is shorter, the IOL tends to kink towards the side with a longer tunnel, because the force there is stronger, and it also causes decentration and also tilting. And with the shorter tunnel side, there would be a tendency for vertical tilting of the IOL, so it in fact would affect the overall optical outcome. So I do have a few cases to share. So this is a patient with the inferior RD silicone oil removal that I mentioned early on with retention of the PFC. He developed the inferior optic capture after the flanged IOL, after removal of the originally dislocated lens. So after learning this, I think in the future I would recommend for cases that you would afraid that there would be risk of the IOL capture, performing a peripheral iridectomy would be a good option for prevention. And this is another patient with a history of, it's an only eye patient. He's a 73-year-old patient with a history of white dye retinal detachment, and this is the white dye is being the only eye. For the left eye, the patient has already undergone hypotenuse changes because of multiple RD failed fixation. So for the right eye, the whole IOL complex being dislocated, so I end up performing the scleral tunnel wound for this patient for removal of the IOL complex and insertion of a PMMA, scleral fixated 4-point fixation by 10-0 Prolene approach. However, postoperatively, the patient developed persistent hypotony, hyphema, vitreous hemorrhage, and choroidal detachment. Given this is the only eye of the patient, I went in a few times for injection of the anterior chamber, suturing all the wounds, but still the IOP is not coming up. And in the end, we performed UBM in this patient and find out that there may be a small iris root or ciliary body cleft causing the excessive drainage, because when I created the scleral tunnel wound in this eyeball with 25 millimeters long, maybe there is trauma to the ciliary body or iris root. So the corneal colleagues help us to put in SF6 gas injection into the anterior chamber, and eventually the eye's pressure builds up gradually. And now currently the visual acuity is 20/40. So another patient who received cataract surgery many years ago with a one-piece PMMA lens, Because the PMMA lens was not good for refixation itself, we intended to do explantation of the lens. However, we use not a very good technique. We use scissors to try and cut the PMMA lens so that we can not reduce the risk for creating a large wound for the patient. But then because when you cut it, it's really hard. It breaks inside the eye like an explosion and causes a scratch at the endothelium and causes a DMD. So then eventually we have to put in the SF6 for reposition of the DMD. And now currently the patient is doing good. So in conclusion, the surgical management for dislocated intraocular lens can be very challenging. And I have to admit that a lot of the time I learn through the mistakes or from the patients or by handling with the complications by arising from the inappropriate pre-op planning. So I hope you can understand more by this sharing, and thank you very much.